Thank you very much for that introduction, and I'd like to thank Colgate for organising this event, and especially to Emmanuel for organising us all and bringing us together this afternoon in terms of the programme. And I'm delighted to see many of my friends and colleagues in the audience who I didn't expect to see, so some of you have heard me speak before, but that's not a problem. But I think what I would like to sort of emphasise is sort of make the connections this afternoon, because actually there are some very profound connections that do resonate very strongly. So I feel the presentations before our break, to me, talked about adaptation, about equilibrium, about balance, about resilience at a microbiological level. But these principles also apply at population levels, and I will refer back to that in a few minutes' time. And I think Hugo's presentation, looking at behavioural insights, highlights the importance of the environment that are conducive to behaviour change in a sustained fashion. And again, I will hopefully make reference to that in my presentation. So to start off with, we started the afternoon with looking at a definition of oral health. Well, a group of colleagues, myself and others, are currently working on some papers, and funnily enough, we are doing exactly the same thing of revisiting the definition of what oral health is. And again, a nice connection to some of the discussions we talked about, but from our perspective as our group, we recognise that oral health is multidimensional. It is about physical issues, it's about psychological issues, it's about emotional, social issues we've heard about already. Very importantly, the integral link between oral health and general health is an important message we've heard repeatedly this afternoon. Another important element we've heard mentioned this afternoon is the variety of functions that the mouth performs, and that's looking at eating, speaking, smiling, socializing. So the central importance of oral health in terms of that process. But possibly most importantly, for today's point of view, is this issue about oral health is about adaptation to changes across the life course in terms of the physiological changes with aging, etc. And the notion that oral health at its core is about self-care, about autonomy, and having the ability to independently maintain one's health. Some of those principles are the vision and goal that ultimately we need to aim for. Now that's the ultimate aim that we're hoping to move on to, and actually a lot of these principles are not new, and I can see some people in the audience, some of us have read Man Adapting by René Dubois, first published in 1965, and that was about the principles of adaptation to our environment and dealing with stress that fits beautifully to what we've heard in terms of the microbiological point of view. Unfortunately, however, the reality of where we are now, and I know many of you are from the UK and across Europe, is in our populations, oral diseases have not disappeared. And indeed, we've got more and more evidence about the burden of oral disorders at our population level. Many of you will have seen and read the Global Burden of Disease study published in The Lancet repeatedly, and for the first time now, oral disorders are included in the disability adjusted life years model that the Global Burden of Disease study uses. And what we've heard repeatedly is that our diseases of dental caries, periodontal disease, tooth loss, rank very, very highly in terms of the range of conditions that are considered. So out of the 291 conditions included in the Global Burden of Disease studies, oral disease, untreated caries comes out as most prevalent, affecting approximately 34% of the global population. Overall estimates are that 3.5 billion people around the world are affected by oral disorders. So our conditions have not disappeared. They're very much still in the population. It's still a major issue in terms of prevention and changing policy. What we also know from emerging evidence, when I trained as a dentist in Edinburgh many years ago, we were trained to believe that caries was a childhood disease. Well, now we know that caries, periodontal disease, are progressive conditions that affect across the life course. Most new disease, caries, for example, is in adults and older people. So that notion that disease is restricted to early life the science, the epidemiological evidence highlights that progressive life course perspective. What we also now know is the impact of oral disorders in terms of people's quality of life, in terms of societal and community impacts, in terms of effects on schooling, educational performance. The evidence we have internationally now demonstrates that our conditions are major public health disorders that are mainstream public health concerns. So that again emphasizes the need for prevention at a population level. In addition, Professor Stefan Listel in the Netherlands, as a dentist and a health economist, has looked at, for example, the costs of dental treatment, and this is taken from the FDI Oral Health Atlas, that oral diseases across Europe are the third most expensive condition in terms of the treatment costs. His estimates were almost 80 billion euros spent in terms of dental treatment. And again, some work we're doing now, he's updated this evidence, and still the most updated evidence is dental diseases are still the third most expensive condition in Europe in terms of treatment costs. Even higher, Alzheimer's disease, respiratory diseases, cancers, etc. So our conditions are a major financial burden to our healthcare systems and to the individuals involved. Another major concern from a public health point of view, and many of us in this room are interested in population health, is the evidence, the persistent evidence of inequalities in oral health at our communities at different points. So one example, just to illustrate this, Tom Dyer from Sheffield, several years ago, looked at population, preschool children, 5-year-old children, looking at their DMF levels versus a measure of deprivation, in this case, income support. And we can see this linear relationship, this very strong association between deprivation and, in this case, caries in preschool children. We all know that. We've all worked with that for many years, but this remains a major, major problem. This is just some data from Public Health England, the most recent 2017 survey, again, as to illustration of 5-year-old children looking at decay experience by levels of deprivation. And what we have is this consistent, stepwise social gradient across the entire social hierarchy. Now, looking across the room, all the different countries we come from, this is a consistent pattern, a universal pattern in terms of inequalities across our populations. These inequalities have not decreased. There's some evidence that they actually may have increased in recent years. So let's now think and reflect upon what Hugo and the others have said in terms of our implications for policy, in terms of moving prevention ahead, in terms of upscaling prevention as a real option to tackle this public health problem. Well, most of us in this room have trained in a dental school biomedical perspective, and in that perspective, we've heard the microbiology, we've heard the importance of fluorides, hygiene, diet, alcohol, tobacco. Of course, these behavioral factors are very important drivers of oral disease at both a patient and a population level. But what I want to present to you is looking at these factors alone is not sufficient to tackle these public health challenges at a population level. So what I'd like to do is briefly, because of limited time, is just highlight the limitations of the traditional preventive approach that we've tended to adopt across Europe, across many countries in both high and low income countries, that hasn't reduced the burden of oral diseases in a sustained fashion. So, here are a list of some examples of effectiveness reviews that have been conducted over the last 20, 25 years. And indeed, Professor Elizabeth Kay is sitting in the very front here, and 2 of her publications are here. But these are systematic reviews that have looked at the published literature on preventive interventions to assess what interventions are successful, what interventions are not successful, and what interventions actually might be doing harm in terms of their impact. And what we know from these systematic reviews is that, of course, prevention can work and indeed does work for many people in our population. We know we can change behaviours. The challenge, however, is sustaining those behaviour changes, again, listening to what Hugo mentioned a few minutes ago. But very importantly, what the evidence highlights is that traditional type of prevention is not effective at reducing inequalities in our populations. There's also concerns about the costs of traditional clinical prevention, the potential lack of sustainability of the effects, and the potential problems of duplication and repetition in terms of interventions. And a useful way of looking at the limitations is looking at what we call the inverse prevention law, that from a public health point of view suggests that some interventions we know can improve health in segments of the population. The problem is, however, it may increase health inequalities between groups in the population. And we've got some good examples in dentistry to provide evidence of this problem. So this is an old study by our colleague and friend Lorna Skoo and Christine White in Edinburgh. And this was an evaluation of a health education program in schools in Edinburgh. And just to explain, these are two outcomes, so zero plaque, so that's healthy, no level of plaque, and no bleeding. So these are positive outcomes. And these are schools that are non-deprived schools and deprived schools. And what you can see is at the beginning of the intervention, there were some differences between the deprived and the non-deprived for no plaque, but for no bleeding, there was actually no difference. However, after the intervention, at the follow-up, 4 months follow-up, what we can see is that the intervention, rather than reducing the inequalities between the deprived and the non-deprived, what happened was they widened. So the intervention increased the inequalities between the deprived and the non-deprived schools in Edinburgh. Now you might argue, well, that's interesting, but that is an old study from 1994, everything's now better and improved. Well, unfortunately, not the case. This is a study just published, in fact, I think it's not even published yet, but in Community Dental Health 2018, a German study looking at exactly the same intervention, school-based health education, and their results were, again, increased inequalities between deprived and non-deprived schools. So this problem of interventions actually increasing rather than decreasing inequalities persists to the current time. Another example of some of the problems with clinical prevention when it's adopted alone, this is a study by Wales Sabah at King's and colleagues looking at the provision of prevention to adults in England, Wales, and Northern Ireland, looking at the adult dental health data that we have in this country. So what they did was look at the provision of prevention by dentists and dental teams by levels of education for the patients. And unfortunately, what they demonstrated were that patients with degrees got more prevention than those patients with no qualifications. So rather than targeting to prevention to those with highest levels of need, it was the reverse, that more prevention was delivered to people with higher levels of educational qualification, degree level. The same applied to restorative, and obviously with extractions, it was reversed, that the people with less education got more extractions. So the message, again, from this paper is the mismatch between the level of need and what we do as professionals in terms of our prevention. So my position is that we need to change or move our paradigm of prevention forwards. So we need to understand the biological processes that we've heard the first part of this afternoon. We need to understand behaviour change and lifestyle, but we also need to understand the importance of the environment that conditions and determines these different levels. So many of you in this room will have heard the issue of the social determinants approach, of looking at the broader agenda in terms of prevention and causation. The World Health Organization, almost 10 years ago now, published its seminal policy document about closing the gap in general health inequalities, but these principles equally apply to oral health inequalities that are directly relevant to us. And essentially, the social determinants of health that the WHO and other global organizations espouse is really highlighting the need to look at the structural determinants, the environment that Hugo mentioned, that conditions the behaviors of our patients, of our populations, and indeed of ourselves, and also to look at the conditions of daily living to change the environments in which our populations live, work, play, etc., to make them more conducive for health, including oral health. So in summary, what we're really recognizing is those wider influences are the drivers of our population health status and ultimately of their well-being and health. And for those of us interested in prevention, we need to be guided by this framework that informs our actions and policies. Many of you in this room will have heard many times about the common risk factor approach, but again, just reflecting on Hugo's presentation, that the success and work on obesity prevention is of course highly relevant to us because free sugars consumption is relevant to dental caries as well as to overweight and obesity. The notions of tobacco, alcohol, lack of control, hygiene, those clustered risks linked to non-communicable diseases is the platform that oral health links in to the broader public health agenda. And having worked in this area for many, many years, I feel really excited and enthusiastic that we're making those connections now much more than ever before. We really are beginning to make the connections across into non-communicable disease arena. But to finish off, let's think about what we need to do in terms of the reorientation of dental services to scale up prevention in a more meaningful fashion. And what we really need to do is we need to have multi-strategies to do this. We need to look at strengthening the individual families and patients that we see in clinical settings. We need to look at communities, the resilience of communities in terms of their ability to work together to improve their health. We need to look at infrastructure, policy, access to services, the multi-layered approach. Again, many of you will have heard of the upstream, downstream analogy in terms of policy arena. That publication is an old one, but John McKinley first talked about upstream in the 1970s. I think 1972 was the first time in California, at a California medical conference, he mentioned this upstream, downstream analogy. But for dentistry, we need to think about improving the prevention downstream, and we've heard some good examples, and we'll hear more examples from our colleagues in Colgate. But we also need to look at the midstream and upstream policy actions that will create the conditions conducive to good oral health. So many of us have thought about evidence-based practice in terms of clinical guidelines. I can see Sue Gregory in the back, Department of Health, Public Health England published Delivering Better Oral Health many years ago. One of the most significant effects of that document in England was the reformulation of children's toothpaste. Sue and colleagues, through that document and the recommendations about fluoride levels in children's toothpaste, changed the market in this country, and that was an example of policy linking to practice and individual prevention. The notion of midstream policy is looking about how we can work in nurseries, older people's homes, hospitals, the workplace, to create settings that are more conducive to good health. There's some examples of that happening, but much more still can be done about integrating oral health into that policy arena. And then lastly, again linking to Hugo's presentation, the options of looking at broader policy recommendations such as a sugar levy is a perfect example of where those policies shift social norms, shift population behaviours, And the best example of that comes from tobacco control, where societies all around the world have shifted their relationship to tobacco because of policies such as regulation and restrictions in public spaces. But finally, we need to look at redesigning our dental services. And I can see Colette and others here who are chief dental officers working in the systems, looking at how we can upscale prevention at a clinical level. And in my opinion, what we need is a real system change to enable our clinical colleagues to deliver prevention in a team approach, using appropriate skill mix that really enables them to deliver prevention. We need to look at reimbursement and incentives that really promote prevention in a meaningful and sustained fashion. We need to use evidence-based approaches in prevention as much as we do in treatment philosophies that link both to oral health and to general health. And lastly, we need to think about how we target our prevention in a proportionate fashion. Michael Marmot talks about proportionate universalism, how we deliver prevention, deliver public health. We have to do the same at a clinical preventive level. And lastly, we need supporting resources for the clinicians to enable them to deliver the prevention in a meaningful fashion. So what I've tried to do from a public health and population perspective is highlight that we still have a significant public health challenge of promoting oral health across our populations, and particularly tackling the persistent inequalities within our groups. We need to understand the role of social and commercial determinants as the key drivers of these disease patterns, and therefore ultimately look at opportunities for integrated interventions at different levels, including upstream policies to create conducive environments for positive health. And lastly, we need to work with our clinical colleagues to reorientate the system to enable prevention to really deliver at a patient and clinical level. So thank you very much for your attention, and I look forward to the questions.